Hey everyone, we're here back for another live on Tuesday for Modifiers. This week I have an amazing guest, as I know you're all excited for me to bring on stage Terry Fletcher. So I'm going to bring on stage Terry Fletcher. How are you doing, Terry?
I'm good. How are you?
I am doing well. I think a lot of us out there probably know me. I posted that I'm in Chicago right now, taking care of my family. My father-in-law is recovering from surgery, so work never stops. I'm here where I am talking about modifiers today, and so I'm glad we got to do this. How are you doing, Terry? How's football season going for you?
Actually, we started off really rough. Everybody who knows me knows I'm a Pittsburgh Steelers fan. But we are now 2-1, and we've had some great games. So very exciting, like Monday night football, Sunday night football. I'm happy. My husband's happy. It's a good week in our household. So when we lose, it's kind of depressing, but no, it's been a good couple of weeks. I know that sounds silly, but
Oh
everyone has
no,
their outlet, right?
they do,
That's
and
my thing.
yeah,
Yeah, see, I podcast on football too, which I actually have to do one today called What the
excellent.
Football. So all the
Yeah, I've
nonsense
been
that goes
telling my
on in
husband to
America.
check you out because he listens to a lot of football podcasts, and he's big into the fantasy football.
Oh, me
So
too.
he's always in a league, right? So he's in a league with my family, and it's last year he won. Really happy for him. He won.
That's
They don't get all
awesome.
fancy and do a trophy or anything, so I said I should probably just get one and do it for you.
Okay, yeah, put it on the shelf for him. I'm in 4 leagues, so talk about balancing that. And I won two last year, and I do pretty well. So it's pretty
That's good.
exciting. That's my outlet. It's kind of like my zen. Now I can regroup.
We all need that.
Yeah,
There's so much going on in healthcare, and our jobs can sometimes consume us, as we know, with what we do every day. It can become all we talk
it
about. But
can.
so that's great. Well, I'm happy to be on today. We've talked about several modifiers, and I know when we originally talked about having you on, it was really just about, really wanting to get down to some of the modifiers that we should use. And if we're not aware of them, maybe we can bring some light to people that aren't aware of them. I do still run into people that aren't aware of some of these F modifiers, as we call them, some of these new on the scene. So
Right.
today, everyone, we're going to bring in FS. That's F as
FS.
in Frank, S as in Sam, so
Yes.
that we can understand what this modifier is used for. So, in general, we understand the split shared concept. A lot of us have been aware of this. When I worked in the hospital for many years as a production coder and auditor, I was aware of the split shared concept. And then, of course, now we have this modifier. So, Terry, just really quickly, a brief synopsis for those that don't know or understand what is split shared services in a nutshell.
Okay, so hard to be brief, but I'll do my best. So, just a tiny bit of background. When physicians and nurse practitioners or PAs, so mid level providers, as I call them, I'm old school, when they share a visit together, so they're seeing the patient both in face to face and non face to face services, what was happening prior to 2021 is that physicians were basically just going to the hospital and signing off on a chart saying, I agree, and getting 100% reimbursement of the allowable for that kind of service. And Medicare said, wait a second, who's doing and they call it the substantive portion, or who is doing most of the work, basically, in lay terms. And then because we now have time as also a way to level your codes, they had to throw that in as well. But time is hard to capture since now our E&M codes also include some non face to face work. So basically, now, fast forward to 2021 and 2023, there was also a clarification in 2022 for hospital services. And remember, and I'll just kind of explain what they say on the Noridian site. It says, first of all, this may not be used in as far as the modifier. Remember, any kind of Hicks Picks modifier, the numerical or the FS, the alphabetical, sorry, may not be used in an office or other setting outside of a facility setting defined as hospital or skilled nursing. So they're trying to make you keep office as incident two rules and hospital as hospital rules. And that makes sense because remember, a doctor can't see a new patient, or I should say, mid level can't see a new patient under incident two in the office. So they don't want you using a modifier incorrectly. So, coming back to the hospital setting, what Medicare wants to do, CMS, is because they really believe that there was a lot of overpayments with shared services, that how they were defined prior to 2021. They want to data mine, if you will, these services. So they want to have a way to track them and determine whether or not they should be paying 85% or 100% of the allowable of the fee schedule. And in my opinion, I think that the mid-levels do most of the work when there's a shared visit. Now, there could be exceptions, but anything as an auditor, anything I've audited, it seems like the physician is only there for a very small part of that visit, especially on rounding visits. Now, when it is initial hospital visits, it tends to be a little different. Sometimes you do see for the most part, you do see the physician is the one that is there. But they go to define the split or shared visit and the use of this modifier in ways that I don't know about you, Jennifer, but I feel like is a little bit inconsistent with the guidelines now. So, for example, we have published guidelines that are very specific on medical decision making. And
Yes.
whoever provides that in its entirety, if you're not doing it based on time, you have to provide either history exam or medical decision making in its entirety, if that's how you're basing it. And then that's who gets credit for this, even if the physician came in for part of the other. But the problem is our history and exam have no guidelines now. It says what the physician feels is appropriate or what the provider thinks is appropriate. And so what is that? We don't know what that looks like. It's what the provider thinks that looks like. Now, if you're clinical, as I am, you can basically say, well, patients being admitted, for abdominal pain, I don't think I really, need to see an ankle exam. I'm giving you the extreme, but you see what I'm saying here.
Absolutely.
Um,
Yeah.
yeah. But the problem is that we are still seeing that FS slapped on something on an E&M code, which is where it goes, when I still believe the physicians aren't supporting their involvement in a substantive manner. So if you truly have done most of the service as, again, a physician, then you should get credit for that. But if you're relying on your mid-level providers to provide the service and you're just adding information from a non-face-to-face perspective, and we have a conflict with AMA, CPT, and Medicare on this, then
As we do
you really,
often.
oh my gosh, every time. We definitely should have that billed under the mid-level provider. And the thing is, once you start slapping on modifiers like FS and FT for other things, and anything that identifies, GWs, identifies things that Medicare wants to look at, that
Yeah,
they want to
exactly.
keep track of, monitor, if you will.
Mhm.
It's gonna open up a Pandora's box to see who really is doing the work, who's really, really doing the work. And so I believe they did this so that they can pay the reality of 85% to the mid levels, honestly.
No, I mean, you're not wrong, and I'm right there with you. And like you said, and like we all say, these modifiers are tracking mechanisms. It's like Big Brother.
Yeah,
They're out there
really.
trying to track what we're doing.
It
And that's
is.
the reason that a lot of them exist, for most of them exist, is something goes on for so long and they keep paying out on a service and they're questioning, and especially when they request records for certain ones and they see a
Right.
pattern, right? Um, that's why we want to track it. We want to see, okay, how many of these are being done. We're going to look at these. We're going to pull these with anything with this modifier on it. We're going to pull it and we're going to see what's going on. And I get lots of questions. And I love Noridian. I love the Macs. They have great information. But I'm going to shout out to my Mac Novitas. I just love the way they put things together. I was on there earlier looking at some of the information. And if you ever just want to look at their website for Southern modifier stuff, they have some great modifier references. So specifically for the split shared, they have an example on there. They lay out for you what a facility is. Specifically, a lot of the Macs do. They tell you what a facility actually is, definition.
They do. Novitas is Noridian had 4 lines, and then they referred you to the online Medicare manual, and then I'm on Novitas right now, and they've got paragraphs and even
Yes.
examples of how to get
Yep.
it done. So they're much more descriptive. I think the thing that's tough with split or shared visits is, so here's the funny part of this when we just talked about CPT and Medicare conflict. Usually Medicare is more conservative. So think prolonged services. They're like, okay, the 15 extra minutes that you want to add on to the level 5 visit starts after you've met the highest time threshold, right? Because we have a range now, which will change next year. So they're actually messing with us. But
I know, right?
I know, right? So they're saying you have to hit the maximum before you can add that extra 15 minutes. Well, CPT says you have to add the minimum. I'm just like, that makes no sense. So 1 minute after you can start counting if you have a range. So the CPT doesn't always make sense to me when they go through their thought process. Well, when it comes to split or shared visits, they are more conservative than Medicare is. So CPT says both providers have to have the face to face. Medicare says, and I'm actually going from what your Novitas says here, they're saying that they should have face to face, but it it says here for all split shared visits, one of the practitioners must have face to face in person, but it doesn't necessarily have to be the physician who performs a substantive portion and bills for the visit. I don't agree with that. Think of being in front of a judge. Do best practices when you read something that's so
Yeah.
silly. I mean, you're in front of a judge and he goes, so you didn't see the patient at all? No. But you're billing out the visit? Yes. But your mid-level saw the patient? Yes. But I basically, and data points are killing us right now, but I did all this review and I ordered all the tests, but you never saw the patient. And I could see a judge or an
Mhm.
arbiter saying that over and over and over again to
Mhm.
a physician going, listen to what I'm saying here. The patient's sick enough to be in the hospital, but you didn't see them and you bill
Like,
for the
repeat
visit.
this back to me, what
I
I just
know,
said.
I know.
Let
So
yourself hear it.
sometimes, yeah, sometimes just because you can doesn't mean you should. How many times do we tell our kids
Mhm.
that?
Yeah,
Just
well, yeah.
because you
I've been told
can.
that.
I know. Well, and there's some published, oh my gosh, you and I have both been like, you've got to be kidding me. There's some published articles on split shared visits out there. And we face plant because we're like, whenever you hear something that says, well, it's technically, oh, so it's not really true, but you could get around it. Or, well, how what you could do is don't call it that. And you're like, what are you talking about?
Well,
So,
and I think we have to, you are definitely correct. Playing devil's advocate here, just in
yeah,
general, we come from different worlds sometimes. A lot of us out there that work in different healthcare spaces. So when I'm thinking about what a coder is looking at to do their job, an auditor is looking at to do their job, a physician, they think of things so differently. But going back to what we do in our jobs, we're auditors, we're looking at documentation, we're
coders, right?
advising people as consultants, we're looking at what the payers, the regulatory agencies say. And there's some water, muddy water here because we have to live by what gets paid, and you can code all day long the whatever's right by CPT standards, right? But to get paid, it's a completely different story,
And
and so
just
you
because you
have to
get
go
paid
by
doesn't always make
Medicare.
it true either.
Yeah,
Sometimes just getting paid doesn't make it accurate.
absolutely.
But the problem I see is a lot of times, and I love our physicians, don't get me wrong, and I love our mid levels, but I do see sometimes a physician will say something to the effect that, well, I can defend that. I'm like, okay, first of all, I'm not a defense attorney, so if you have to defend that, I'm out. If
Mhm.
you're saying that it's probably not appropriate, but you don't like the policy, so now you're going to defend it. Do you have a defense attorney on speed dial, or are you retaining that? Because
Yeah.
that's what you just said to me, that you're willing to put in the expense, put your reputation on the line, and invite the risk. I mean, Sean
Mhm.
Weiss and I,
I
we
was just
do,
going to mention him from
yeah, we
yesterday
do
when you
a
guys were
couple of
talking about that.
podcasts. Yeah, we were talking about that. And he's the first one to say, because he does this defense work and not as an attorney, but
Mhm.
as a consultant and with attorneys. And he's like, well, I'm on the defense side, so I'm after you get in trouble,
Yes.
and you and I are on the proactive side. We're trying to keep you from getting into trouble to have to call him. So, as soon as somebody says that to me, the hair on the back of my neck stands up and I'm like, okay, well, good for you. I'm glad you said that. What I'm seeing in the documentation is not defendable from a payer perspective,
Mhm.
trying to get you a clean claim out. And,
Yeah.
if they question it, and if you end up getting a UPIC, a CERT, a TPE audit, I said,
All those
now you're in
acronyms.
trouble. Yeah, I mean,
Yeah.
let's just keep going. Even if it's not just Medicare. And if you're saying, well, I can defend that, you just to me said that you have a defense attorney on speed dial and you're willing to put in the expense and invite the risk. And that's not a good way to practice medicine.
You are 100% correct. No, I agree with you. And, we know that a lot of you different, we say the word providers, we know physicians, and then our advanced practice practitioners. Um, or advanced, I don't know, APP, whatever it stands for.
Yeah.
It is National APP Week. So I wanted to shout out to all of you out there and say thank you for all the work you do. And we are here as consultants to help you. If you have
We are.
questions for yourself, we both do audits that involve that type of work. Help you communicate, with your physicians and vice versa. Because I will say I am seeing audits recently where, unfortunately, because of the documentation, the APP is getting shafted
Yeah.
because the information is not accurate for their portion of it. And so I also feel for you because you also are getting shafted at times by not having the accurate documentation. So I encourage you to have that communication. In 2024, we are going to have our practice management symposium. So one of the things we do want to ask is, if you are a practice manager, it's part of your role to make sure that your team members, your physicians, your APPs, that they are also trained and understand the ramifications. So it's a good idea for you to attend as a practice manager, to attend this. You understand the implications of that. And a lot of these modifiers are going to be at our upcoming boot camp. So just a real quick reminder, our live boot camp in Dallas, Texas is coming up too quick in October. And then we have Daytona in December. And the week later, we're going to be in Tampa on the 16th of December, followed by St. Louis in March. So we have a lot going on. I want to throw those dates out there. You can go ahead and go to our website at healthcareinspiredllc.com and check that out. And we'll also put in the chat, we'll put in the notes there, the actual link to purchase. If you want to attend, it's a great way to support your practice with education for those that really need it. Get those modifiers on there that actually help you track the data, but also get you paid and properly so you can keep the money.
One of the things also, just I know that we're kind of wrapping up this segment.
Sure, yeah.
With the FS modifier, it's not just for the mid-levels. It's for anybody that bills a shared visit. So as soon as you have two providers that are able to bill independently for a single portion, and that's actually what they say on quite a bit of the different policy and MAC carriers websites, for anybody that can bill directly to Medicare for an E&M service. So as soon as two providers are involved, that FS modifier is going to have to be attached to that E&M. And again, it's for hospital codes. And so you just have to know it's facility only. It's not for the office, no matter what anybody tells you. And so place of service 11 would not be allowed. And it's really important to make sure that, it's if the doctor does it in the mid-levels there, even if it's the doctors did the substantive portion or had more time, they still have to put the FS on it. For some reason, Jennifer, when this modifier first came out in 2022, everyone thought it was just a shared modifier or shared visit modifier if the mid-level sent it out. And I'm like, no.
Yeah, no, it's for either.
No, it's for either.
Yeah, we'll have two questions we'll just take real quickly, just so we can get some of your answers, because I know some of you are jumping on. So John, of course, friend John, we love you, John. How does one out of the three elements of the encounter become a substantive portion? Wouldn't two of the three be substantive? What do you think, Terry?
So you still have to have 2 out of 3 elements, but to be able to bill it as you're the provider that gets to report it, one of those 3 elements has to be completed in what they call in its entirety. So it can't be, if you're just doing the substantive portion, then you can have part of, the history, part of the exam, part of this. But if you're billing it out specifically, then it has to be a complete, they call it in its entirety. And because we only have published guidance for the medical decision-making, that's what I look for. So because we don't have published guidance for what exactly is its entirety for the history and exam, it's hard to define what that is. And I think that leads people down the wrong path.
Understand. One more question here. What if a physician signs a note that is documented by the APP and they claim they were used as a scribe? Would they need an attestation for scribe or bill it with no attestation?
Oh, I hate this question.
I hate these questions. Yes, too.
Yeah. So if they're used as a scribe, then they're not supposed to have any part of that.
Yeah.
Here's the problem. And I audit for payers, including Medicare. If you use an APP as a scribe, nobody will believe you. Are you saying that somebody who has the education of a qualified healthcare professional, of a nurse practitioner or a PA, somebody who can bill independently and has independent medical decision-making qualities under their licensure, is not going to have any input? Right. That's ridiculous. Scribes are medical assistants, are medical secretaries, and not to discount how important they are. They have no medical decision making qualities at all under who they are. They also don't have any required certification or licensure,
Right.
so there's nothing required. There's recommendations. But if I see, and I do see that every once in a while, I have one doctor in particular that says, well, my nurse practitioner is my scribe. I'm like, no, she isn't. I'm like, that's a good try though. And he's like, no, really, she is. I go, really? I go, you're paying her $160,000 a year to be a scribe? On what planet? I'm like, try to prove that.
I love
So
it.
yeah,
Yeah.
nobody will believe it. Good try though.
No, I love it. No, it's great stuff. And thank you everyone for coming on today. This was a quick modifier tip Tuesday. So thank you, Terry, for coming on. And Terry Tuesday, by the way.
Terry Tuesday, yeah.
Happy Terry Tuesday to everyone.
There you go.
And we'll catch the replay, guys, if you missed it. And we'll look forward to seeing you. And then, of course, always check out Terry's podcast, Codecast, one of my favorites. This week's episode is a must listen. And, of course, check her out with Sean Weiss on Terry Tuesday. Great stuff. Thank you, Terry, and have a wonderful week.
You too. Thanks for having me.